fit well within the rubrics of these more priority populations for the Commonwealth Fund. Our quantitative methods are going to adopt an interrupted time series to measure the differential outcomes of Hennepin Health on utilization and cost. And we're going to really try to work to construct comparison populations from the unexposed Ramsey County population, as well as from likely a propensity score match sample of people within Hennepin County who did not get exposed to the care model, worrying a lot about the great outcomes that Ross can show and the analytic work that Dana is already doing, but trying to sort of bring some of the scientific quasi-experimental approaches to overcoming that selection bias and to trying to sort of critically evaluate some of the findings and see and hope that they stand up, but really try to look at that from an objective lens. Our time frame, as you'll see, stretches from the beginning of this population's availability on Medicaid, which was in March of 2011, so the sort of pre-Hennepin Health period, through the rollout of the program and on to June of 2014. And we're going to be looking at some of the traditional utilization metrics that you would think of: inpatient admissions, ED visits, outpatient visits, overall medical costs, but also trying to drill down on some of the details that Ross mentioned, where we have a lot of reason to think that we might start to see differences in length of stay, in readmission rates, in time in the ICU, and in quote-unquote preventable admissions. And we also feel challenged by our data source, which is Medicaid claims for this portion, the enrollment and encounter data from Department of Human Services on the Medicaid expansion population, to sort of capture some of the rich social factors that Ross was describing. So we've put a lot of our early time and work into trying to understand some of the ways that we might get at this social context of the patients from an otherwise pretty limited data system of the claims. So we do have rich enrollment data that describes age, sex, race and ethnicity, education, and marital status of the population. We have home address, which we've been able to use to build an indicator of the census tract socioeconomic situations that individuals are living in. We've also flagged diagnosis of homelessness and unstable housing, but we know from the literature that this is at best about 25% accurate in identifying people with active homelessness. So we also took some creative liberties building on some of the relationships that Ross and Dana and others had with people in the county to think more creatively about how we might get at homelessness. So we have created a flag that identifies when someone uses a known shelter or transitional living in facility from the county housing authorities or housing navigators, as well as from the general delivery address. And clinically, as a provider at Hennepin County Medical Center, I can tell you there's a really high number of patients who use the general delivery address as their home address. And in this state, when you apply for Medicaid, you have to put an address. So those who don't have an address or don't have a friend's address or don't have a family member's address often will put the general delivery address. And the Minneapolis general delivery address has a zip code that falls within the sort of primary catchment area of Hennepin Health. So that's been one of the drivers that we're trying to understand, but we find an astronomically high rate of homelessness and by these flags within our data. And we're also able to compare this, and I can talk more after to people who are interested, with self-report of homelessness based on some survey data that Dana has collected within the EPIC electronic health record on Hennepin Health people. So on the clinical face of Hennepin Health, there's this acknowledgement of the social factors. So there's a lifestyle overview survey that asks people questions across a variety of different domains, from do you have a telephone to do you have people to call in time of an emergency? And we've got tracking on those responses and have been able to use that to validate this homeless flag that we built to ensure we're really measuring what we think we're measuring. And then we also are looking at diagnosis code groupings of people who are experiencing mental health and chemical dependency as another way to try to get at some of these broader contextual factors that we know are at play with Hennepin Health patients. Our qualitative aim in the study is hoping to drill down into some more of the richness of the patients and the care model. So we're hoping to identify the key elements of the care model as perceived by enrollees and their multidisciplinary providers to describe the quality of care and quality of life during program participation. So we're hoping to do and planning to do in-depth theoretically guided key informant interviews after having reviewed someone's electronic health record charts and Hennepin Health scorecard internal data that's collected on their broader use. to understand who these people are and trying to sort of guide them in some kind of a reflective interview about whether or not they even know they're in an alternative care model, what pieces of the care model seem to float to the surface and matter to patients, guided strongly by some of our hypotheses about relationships and about sites of care and about how providers may have engaged in shared decision-making practices to really meet patients where they're at. And we're hoping not just to talk to healthcare providers, but also to talk to people on some of the county social service and outreach sides, the community health workers that Ross mentioned, and to hopefully inform who we talk to by the people who we know from the health record are the people who are having the most contact with these individuals. And our goals in this phase will be to understand the elements of Hennepin Health perceived as important to different types of enrollees and under which circumstances, as well as to describe perceptions of patients, these very high-risk patients. I think we know very little about what they believe to be quality of care and how that lines up with any of the metrics that we're calling quality of care measures, and to also think somewhat about the quality of life that individuals might have experienced and if there was any narrative change in that experience during their involvement with Hennepin Health. So overall, our goal is really to try to create a synergy between the practice of research, the operational environment of Hennepin Health, and the health improvement of this population of high-risk individuals. We're hoping that we can strengthen the delivery of the care model by developing and validating measures that we can kind of work closely. Dana and I keep in pretty close touch most of the time, and that we can increase internal administrator and leadership awareness of the program across the different partnerships. We can improve the patient and provider engagement in what is Hennepin Health, why should we treat these patients differently, and how that sort of intersects with the broader scope of work that's done in the county and at HCMC. And how we can identify and expand the areas of strength and things that are working, and identify and improve areas of concern and areas that there might be some struggle or some gaps between what we want to happen and what's actually being executed. And overall, sort of draw some evidence-based lessons to share with these people who are calling and wondering what pieces of this program are working, how and why, and we can have some internal confidence that the lessons that we're sharing and the narratives that we're having are based in the data, at least the data to the best of the abilities that we're able to measure it at this point. And with that, I'm happy to take any comments or questions. I think we're going to move into Q&A so we can kind of go in whatever direction you all feel interested. I'm going to put up as well. I'm happy to stay in touch if people have interest or questions further.
So I'd like to open it up for questions now. I can maybe start it out, and I'm wondering if this program is generalizable to other situations, or if it's unique to Hennepin County, unique to a county